Okay, so now for part two of the respiratory system, we're going to talk about pulmonary ventilation. Pulmonary ventilation is the act of moving air into and out of the lungs. So this is the first process of respiration is breathing, or pulmonary ventilation, and it consists of two phases, inhalation or inspiration, which brings air into the lungs, or exhalation or expiration, which moves air out of the lungs. This is a pressure-volume relationship, which is going to provide the driving force for pulmonary ventilation. Now, let's look at the air first. Air is a mixture of gas molecules. Gas molecules will move from areas of high pressure to areas of low pressure. These pressure gradients, or differences in pressure between two different areas, will drive movement of air molecules during inspiration and expiration. Boyle's law, which describes the relationship between pressure and volume, states that at constant temperature and number of gas molecules, pressure and volume of gas are inversely related, such that as the volume of container increases, the pressure the gas exerts on the container decreases. So as volume increases, pressure decreases. On the flip side, as volume of the container decreases, the pressure the gas exerts in the container will increase. So as volume decreases, the pressure increases. The process of pulmonary ventilation, which involves inspiration and expiration, involves volume changes of the thoracic cavity, as well as leading to volume changes in the lungs that will lead to a creation of pressure gradients. The pressure gradients will then cause air to move into or out of the lungs. There are three pressure gradients that influence pulmonary ventilation. The first is atmospheric pressure. Atmospheric pressure are the molecules that make up the air that are subject to the force of gravity. The pull of gravity on the air around us creates what we refer to as atmospheric pressure. At sea level, which is where you guys are at in Philadelphia, atmospheric pressure is about 760 millimeters of mercury. It increases as you go below sea level, but it also decreases as you rise above sea level. So a city like Denver, which is significantly at an elevation above sea level, the atmospheric pressure is actually going to be a little less. The second pressure gradient that influences pulmonary ventilation is intrapulmonary pressure. This is the air pressure within the alveoli, is called intrapulmonary pressure. It rises and falls with inspiration and expiration, and always eventually will equalize with atmospheric pressure due to pressure gradients reaching equilibrium. The third pressure is intrapleural pressure, and this is the pressure that's found within the pleural cavity. Like intrapulmonary pressure, intrapleural pressure also rises and falls with inspiration and expiration. This does not equalize with atmospheric pressure, normally about 4 millimeters of mercury less than intrapulmonary pressure. This difference is due to the slight suction effect that's created by the tendency of the lung to collapse and the chest wall to expand. The pleurifying fluid is constantly pumped out of the pleural cavity into the lymphatic vessels. This creates slight vacuum that in effect glues the two membranes together. So now how do these pressure changes occur during quiet ventilation? During the first step, the lungs at rest between breaths, intrapulmonary pressure is the same as atmospheric pressure. They're both equalized at 760. If both atmospheric and intrapulmonary pressure is at 760, no air flows in or out of the lungs. Now keep in mind, again, the intrapleural pressure is actually going to be a little bit lower than atmospheric, and that will be about 756. Now for the process of inspiration to occur, intrapulmonary pressure must be less than atmospheric pressure. And in order to do that, you need to increase the volume of the thoracic cavity, which will increase the volume of the lungs. And the diaphragm and the ribs, the muscles of the ribs will accomplish this, and that will cause for an increase in the volume within the lungs, which will decrease the intrapulmonary pressure to about 758. Atmosphere doesn't change, atmosphere is 760, so now you're going from a layer of higher to lower. And when that occurs, airflow will now occur inward into the lungs. Air will continue to move into the lungs until the gradient no longer exists. This happens when intrapulmonary pressure equals atmospheric pressure. At this point, between inspiration and expiration, no movement occurs, as there is no pressure gradient to drive its movements. Now, in order to get air to move out of the lungs when the pressure gradient is created during expiration, what happens is the intrapulmonary pressure rises above that of atmospheric pressure. So you're decreasing the volume in the lungs to where now that's going to increase the pressure to, say, 762. And what happens then is air will move again from higher to lower. It's actually going to end up moving out of the lungs. And again, the process of expiration will stop when intrapulmonary pressure equals atmospheric pressure. Okay, so this just kind of goes through the 4 steps of pulmonary ventilation. It just tells you what each of the pressures are at any given point here. So now what happens if intrapleural pressure increases to a level at or above atmospheric pressure? Intrapleural pressure no longer exerts suction effect that prevents the lungs from collapsing. The added pressure enhances the lungs' elastic recoil, and the lungs will immediately collapse. Many things can increase intrapleural pressure above atmospheric, including excess fluid, which is referred to as a pleural effusion, air, which is referred to as a pneumothorax, or blood, which is referred to as a hemothorax within the cavity. So this illustration shows if you sort of have a stab wound, okay, into the thoracic cavity, that can cause the lung to collapse. That will have to be repressurized, and first of all, you have to plug up the hole and then repressurize in order to expand these lungs back out, or lung back out. This could also be the trauma. If a rib can puncture through as well, that can cause a pneumothorax. So now let's look at the mechanics of inspiration and expiration. The volume changes during ventilation rely on skeletal muscle of the thoracic cavity. The lungs cannot change their volume on their own. Muscles increase the lung volume indirectly by increasing the volume of the thoracic cavity. The parietal pleura, which is attached to the inner surface of the thoracic cavity, as well as the thoracic cavity, will expand. It pulls on the parietal pleura, pulls on the visceral pleura, and then as a result, you'll end up pulling the lungs outward, increasing their overall volume. So looking at the inspiratory muscles, we have the diaphragm. This is your main inspiratory muscle. It divides the thoracic cavity from the abdominal pelvic cavity. It's a dome-shaped muscle when relaxed, and it bulges up when it bulges up into the thoracic cavity, decreasing the volume of the lungs. When it contracts, it pulls down to become flat. During the contraction, this increases the height of the thoracic cavity, increasing the volume of the lungs, decreasing the pressure, so then airflow moves in. The external intercostal muscles, these are the muscles between the ribs. This is on the external side. When relaxed, the external intercostal muscles cause the rib cage and therefore the lungs to be at a reduced size. When the external intercostals contract, they pull the rib cage superiorly and anteriorly during contraction, so up and out. This increases the height and the diameter of the thoracic cavity, which again would increase the volume, which would decrease the pressure, and you have airflow move in then as well again. When inspiration is deep and forced, the inspiratory muscles contract more forcefully. In addition, accessory muscles of inspiration contract and further increase the size of the thoracic cavity. This will include the internal intercostals, the pec, sternocleidomastoid, scalene, serratus anterior, and certain back muscles of the erector spinae group. Unlike inspiration, normal expiration is typically a very passive process. It does not utilize muscle contractions. Two things happen when the inspiratory muscles relax. The diaphragm will return to its original dome shape and it pushes up on the lungs. The elastic tissue in the lungs will start to recoil. The recoil in the diaphragm relaxation together decrease lung volume and raise intrapulmonary pressure above that of atmospheric pressure. So then now you're creating that decrease in volume, increase in pressure, which now forces air out because it's greater than atmospheric. And this just shows you the events that are occurring during the actual process of ventilation there. Now, we do have some accessory muscles of expiration. This is used for forceful expiration. So if you're forcefully exhaling, but this also goes for coughing, sneezing, yelling, screaming, where you have all of those forceful expirations of air. This will include the internal intercostals and the abdominal muscles and certain back muscles. What they are doing is they are forcefully decreasing the size of the thoracic cavity. Reason why the abdominal and back muscles are so often sore after having a cough. The Heimlich maneuver, which is delivering abdominal thrusts that push up on the diaphragm, is used in people who are choking in hope that the forced expiration will actually dislodge the obstruction and hopefully allow for restoration of breathing. So this table just summarizes the various muscle groups that are responsible for inspiration and expiration. There are also several non-respiratory movements. These are not intended for ventilation. They can include things such as yawns, coughs, and sighs. Sigh is a slow, deep inspiration that's held and followed by a slow expiration. This reopens local groups of alveoli, and it can stimulate the release of surfactants. A yawn, this is a large sigh. It takes lung volume to inspiratory capacity. When tired, it will minimize alveolar collapse during sleep. After sleep, it opens the alveoli that collapse during sleep. A sneeze, this is a deep inspiration followed by a large forceful expiration through the nose. It can have a speed of about 100 miles per hour. And the job of a sneeze is to clear foreign material or irritating substances. A cough is similar to a sneeze, except the initial expiration is small or absent. The velocity from a cough can be almost 500 miles per hour, which clears the larynx, trachea, and local lower airways. And here's a table that summarizes the 4 main types of non-respiratory air movements there. So there are 3 physical factors of the respiratory tract and lungs that can influence overall effectiveness of pulmonary ventilation. The first is airway resistance. This is defined as anything that impedes the flow of air through the respiratory tract. The second is alveolar surface tension. The alveoli are covered with a thin film of liquid composed mainly of water, creating a gas-water boundary. And the third is pulmonary compliance, which refers to the ability of the lungs and the chest wall to stretch. So let's look at airway resistance first. This is largely determined by the airway diameter. Resistance decreases slightly over inspiration as the airways are pulled open and the lungs expand. Resistance increases slightly as the lungs recoil and the airways narrow due to expiration. The diameter of bronchioles is controlled by smooth muscle contractions and relaxation. Relaxation, which is bronchodilation, increases the diameter of the bronchioles and decreases airway resistance and increases airflow. Contraction, or bronchoconstriction, decreases the diameter of the bronchioles, increases airway resistance, and will decrease airflow. There's also the second thing is called alveolar surface tension. This is another factor that affects pulmonary ventilation. Alveoli are covered with a film of liquid, which is mainly composed up of water. The gas-water boundary exists within each alveolus, where water molecules form hydrogen bonds due to their partial charges. Gases are nonpolar molecules and therefore do not form hydrogen bonds. This will create a surface tension at the gas-water boundary. This is greatest when the alveoli are at their smallest diameter during expiration. The high amount of unopposed surface tension causes the alveolus to collapse during expiration, called sorry, I just lost my thought there for a second, guys. So the high amount of unopposed surface tension causes the alveolus to collapse during expiration. Surfactant, which is a chemical that's produced by the type 2 alveolar cells, is a component of liquid film coating the cells of the alveolus and opposes surface tension of collapsing forces. The chemical structure is very similar to that of a detergent. It has both polar and nonpolar ends, and what it does is it's going to disrupt the water's ability to form those hydrogen bonds with itself, therefore reducing the surface tension and allows for the alveolus to remain partially open even during expiration. Okay, so with the surfactant, what you're getting is, without surfactant, you get this complete collapse here. With surfactant, you're able to maintain the openness of these alveoli there. The third factor is pulmonary compliance. This is the last physical factor that influences the effectiveness of gas exchange and the ability of the lungs and the chest wall to stretch. This is also determined by three factors: the degree of alveolar surface tension. Increased surface tension resists the ability of the alveolus to inflate, decreasing compliance. Surfactant counteracts this collapsing force and increases compliance. The second is the distensibility of the elastic tissue. This gives the lungs the ability to stretch during inflation and increases compliance. The third is the ability of the chest wall to move or stretch during inspiration, and this increases compliance. If compliance decreases, the lungs are less able to expand, and effectiveness of pulmonary ventilation will decrease then. The next few slides will actually go over various pulmonary volumes and capacities. These are things that can be read by a spirometer. Just look over these. These are more definitions, defining terms with sort of defining values. If you're going through and you go through these battery of tests, looking at all of these various types of volumes here, and what they can conclude from this is, by going through these various batteries of tests, is, do you have any deficits anywhere? Do you have any, they can look at this for, say, chronic obstructive pulmonary disease, COPD, or do you have, early stage, or which stage of emphysema are you? Okay, so there's the battery of tests. They'll essentially put you in a sealed room or area, and they will expose you to different pressure conditions, and they'll ask you to breathe deeply, breathe shallowly, breathe normally, and you're sort of hooked up to these sensors that will pick up all these changes. Okay, and that is it for recording number 2.